This is the place to find yourself.
Istanbul offers great universities and the lifestyle is really amazing here.
So I live at the dorms at Maltepe University and I'm really happy with it. There's a cleaning service every few days and then there's the library nearby which is open 24/7.
My first impression when I came was like, it's huge. You have everything in one place.
When you first come to Maltepe University, you don't know where what is and you're like, oh my God, I need help. Guess what? You're not alone. There is the international office people over there. They're like family. They're very helpful and they're always there for you.
Istanbul is the perfect mixture between ancient and modern. Coming into this city helps me discover myself, learn about so many different cultures, learning about the world, which will help me in writing future books.
At Maltepe University, we have a lot of research centers. Because of that, we have the ability to participate in a lot of international projects.
Here at Maltepe University, the education consists of both practical and theoretical. We get the opportunity to practice everything we learn in class in real life. So after we graduate, we have a degree and we can work all over the world.
People come to Istanbul all the time, but what they really miss when they visit are the antique shops, which contain thousands of years of memories and also a thread of the modern future.
I like to use every minute and just get out and hop on the ferry and just go from the Asian side to the European side and just enjoy the wonderful weather with the wonderful Bosphorus behind me and just enjoying the moment of Istanbul.
Istanbul is very beautiful with great culture.
This city is the symbol of diversity. Come and study at Maltepe University.
Come here and feel like you're home.
Good afternoon. I am Özge Durmuş. I am the moderator of this session. This session's first presentation is Safety of Health Workers by Muhammed Rahel.
Yes.
You can start when you're ready.
Yes. Hi
Okay.
everyone. Hi everyone. This is Muhammed Rahel from Bursa Ulda University Medicine Department. First of all, I would like to thank my parents for their support and love to me. Secondly, I would like to thank Maltepe University for this wonderful conference, and also I would like to thank our moderator, Özge Durmuş, for her beautiful management. At the same time, I would like to thank my teacher from the university and school for their guidance to have a beautiful future. Today, I would like to talk about the safety of health workers. Why is the safety of healthcare colleagues important? As you know, it is impossible to be strong and happy without being healthy. Yes, it may be possible to buy horses and cars with money, but it is impossible to buy health with money. That is why being healthy is important for all people. What should we have for the safety of all people? For the safety of all people, we should have fresh water, we should be in a safe environment, and we should have enough personal protection equipment in necessary cases like tuberculosis, coronavirus, and infection cases. And we should breathe fresh air. And we should get a standard living from food, clothes to transportation, etc. But unfortunately, many people don't get the same healthcare which all human beings deserve, and they become patients because of the different reasons like socioeconomic problem, shortage of food, region like America, Turkey, Bangladesh, Myanmar, etc. In every region, there will be different diseases, shortage of food, dirty water, etc. Whenever someone becomes unhealthy, he or she goes to hospital for medical treatment. In hospital, who will treat the patient? Of course, the doctor, the healthcare. For that, the safety of healthcare colleagues is directly proportional to the safety of to the health of patients and a beautiful tomorrow. The risks of healthcare colleagues. According to WHO, World Health Organization, 8% to 38% of healthcare colleagues face physical violence at some points in their careers around the world. Around the world, we have 2% to 5% of healthcare colleagues. But in coronavirus pandemic, we have about 14% of COVID-19 healthcare colleagues facing. Why? Because for not having enough oxygen, not having enough personal protection equipment, and also not having plan and preparation for pandemic, and not being in a safe environment for healthcare colleagues. Physical violence is increasing against healthcare colleagues. It is very dangerous. And also using bad words by patients or close ones is also increasing. Infection diseases are always risky for healthcare colleagues. That is why we must have a safe environment for healthcare colleagues to give the best service to patients. In Turkey, according to MEMUSEN, in last February, we have 43 healthcare colleagues victims. It is a large number. It must not happen. According to Tuktabiklar Birliği, TTB, 550 healthcare colleagues are not with us because of COVID-19. May Allah grant them Jannatul Firdaus. Safety environment. Healthcare colleagues always love to give the best treatment to their patient, but because of different reasons, they become victims of violence that is committed by patient or close one in hospital. Why is that happening till now? The violence against healthcare colleagues must stop right now and right here. The healthcare colleagues are in hospital for your health. That is why a safe environment with necessary laws is needed to keep the safety of healthcare colleagues, both in Turkey and around the world. During the pandemic, healthcare colleagues are shared by many politicians around the world for their brave and unbelievable performance against COVID-19. Yes, it is a great thing. But my question here is, what are you doing, Mr. President, for the safety of healthcare colleagues? And Mr. Prime Minister, what are you doing for a safe environment of healthcare colleagues? Or are you just sharing your clipping picture on the social media? If you are doing so, we will say no to you. And another question to opposition leader, because in a democratic country, there will be a government and a opposition leader. And my question to you is, what will you do for healthcare colleagues when you become in a government position? Because I am asking this question because the safety of healthcare colleagues is directly proportional to the health of patient. If a doctor is healthy, and he will give the best performance to the patient. If a nurse is healthy, and she can care the patients. If ambulance staff is happy and healthy, and he can bring the patient to hospital. That is why the safety of healthcare colleagues and safe environment of healthcare colleagues is directly proportional to the health of patient. During national disaster or any other emergency situation, healthcare colleagues are on the ground to treat patients while normal people are moved to safe places. Without having a safety place, a safety environment for healthcare colleagues, it is impossible to keep people healthy. That is why zero tolerance policy against violence is needed. Zero tolerance policy, it's like number one, education campaign for the safety of doctors. Education campaign to know the right of patient. Poster campaign by both government and opposition to respect the time and service of healthcare colleagues. Because in a democratic nation, there will be government and opposition. The government will have over the 50% of supporters and opposition will have less than 50%. And there will be people who don't like the policy of government. If zero tolerance policy is a national policy, there will be no country in the people who will not like the policy. That is why zero tolerance policy must be a national policy. make zero tolerance policy as a national policy. Necessary punishment. We must have necessary punishment. Who broke the safety of healthcare colleagues? Number 6, keeping the greatest budget for healthcare sectors in the country. Number 7, education training to healthcare colleagues for a better treatment under a national healthcare program. And we must build necessary school, building universities and hospitals to have more healthcare colleagues in the future. Number 9, giving necessary time to patients. Thank you so much for your time.
Okay, thank you for your presentation. Is there any questions? If not, we can continue with our next presentation. Quality of medical services under COVID-19 by Alam Sahavaj. Sahavaj Alam. You can start if you're ready. I can't hear your voice. Unmute yourself. I still don't have your voice. Like, hear your voice. I think we have problem with microphone. Yes, now I have.
Hello, are you able to hear me?
Yes, I can hear now. You can start if you're ready.
Hello. So, good afternoon, everyone. I'm Sehwaj Alam, and I'm studying in IK Akonbhai Kyrgyz State Medical Academy in Kyrgyzstan, Bishkek. I'm basically from India, and today I'm going to present my presentation on the research I've been made on the topic quality of medical services under COVID-19 pandemic. Like, quality is one of the key components of the universal health coverage in the line of the sustainable development goal. And today it is estimated that high quality healthcare system can prevent half of all the maternal death and 1 million of the newborn deaths each year. So to raise about this concern, I'm going to present my presentation on the research in which I'm examining the ability of the sexual and reproductive health services in pandemic and after the pandemic. The comparison I have made, like as we know that in pandemic there's a state of emergency is there, social distancing we need, and outpatient is reduced, visits reduced in hospitals because of home isolation, which disrupts the sexual and reproductive health services, both in globally and India. So I made a survey from India and from various states like New Delhi, Uttar Pradesh, Rajasthan, and this survey is continued for the 2 days in 20th and 21st of January in this year, and that previous also on the same date. So in previous year in 2021, we can see that 96 women of the reproductive age had been interviewed, and now in this year 93 women of reproductive age interviewed. So this type of questionnaire I have formed to achieve this goal. Like in this I have put the question about the family status, contraception, and like unwanted pregnancy, abortion, infertility, violence of family, pregnancy management, postpartum patronage or hemorrhage, and danger signs during the pregnancy they were knowing about or not. So basically, I made this questionnaire and sent to my females, friends and families, and they circulated to the various females in the cities and the village. So they answer, they respond in this. So basically, I found that average age of the respondents is 30 or plus 30. Like it's between the 22 to 45 years of age, and their family status, that 61.4% of the family who responded is married, and 63 of the women live in village, and 37 is living in the city, and 43% of the respondent is with higher education is there. So I made the comparison of two three things. I made a comparison, like contraception. Like in previous year, 25.30% female wants the contraception, and this year 31.10. And the services they need in the pandemic, due to the home isolation and everything is closed that time, 24.09% only got the services, and now this year it's like 43.5%, it increases. So this I found from the survey. And if we see that, like unwanted pregnancy and abortion, in previous year it was 19.2, that the female wants the abortion, and this year 22.2%. But we see that there is no much difference we can see, like in pandemic and after the pandemic. It's like in previous year 14.4% only women only got the services of abortion, and this time only 18. So it's not very much differences there I've seen. And then if we see the violence, that previous year there is 12% women needs have the violence, and in this year 13.9% have the violence. But if we see that previous year, like 13.5% of women got the services against the violence, they are being held. But this year, like 15.78, it is also not much more in India also. So I basically this survey I have formed, and like I achieved that there's some in some cases they increase the services, and in some they are not. So basically, in conclusion, I found that restrictions such as lockdown, home isolation, and reduction in outpatient visits, and everything that was closed at that time, have significant impact only on the contraceptive services, which increases after the pandemic. But at the same time, we see that possibility of abortion service, getting abortion and receiving the violence is not much more. It remains low. It's not very much differences there, regardless of epidemiological restriction. So this is my survey presentation. So thank you so much for your attention.
Thank you for your presentation. Is there any questions? If you not have any questions, we can continue with our next presentation. Climate change impact on food-borne disease. Johnson, we are going to connect with Johnson. Hey. Johnson, can you hear me? Okay, then we will return to Johnson. We will go with the next presentation will be knowledge of reproductive and sexual rights among students. Iluri Partip. Okay, then we will go with an orphan disease heredity in evolving health. Baş Sümbül.
Hello.
Hi. If you're ready, you can start.
Hello attendees, my name is Bar Sümbül and I am from Maltepe University, Faculty of Medicine. I would like to thank the Presidents of Congress and the organizing committee. So, an orphan disease, Heteroangiodema in the evolving health. It contains in the introduction, what is the angiodema, the reasons of angiodema, symptoms, and the modern medical pharmacotherapies for angiodema. So, first of all, what is the orphan diseases? An orphan disease or a rare disease is defined with a prevalence of 1 to 75 per 10,000 inhabitants. It depends on age, genetics, especially mutagenetic factors and environmental factors. So what is heteroangiodema? The heteroangiodema is a rare disease with repeating angiodema episodes that might cause mortality. C1 inhibitor controls the bradykinin levels, which is one of the most effective vasodilator molecule. Therefore, C1 inhibitor deficiency or dysfunction in heteroangiodema is related to vasodilation and edema. So we can see the C1 inhibitor molecule and the symptoms of heteroangiodema. So let's check out. C1 inhibitor controls the bradykinin levels and the factor VIII and the complement system. If C1 inhibitor levels decreasing, then it affects the bradykinin, kallikrein, and the cycle of complement system, and it's responsible for the edema, fever, rash, and the other biological symptoms. So if the C1 inhibitor levels decreasing, then the damage to endothelial cells activates factor VIII and plasma prekallikrein. So, angiodema and the heteroangiodema, what is the difference? The difference of angiodema and the heteroangiodema is if the patient heteroangiodema attack has an heteroangiodema attack, so it can't be treated by the modern pharmacotherapies, which is the cortisol or the corticosteroids, adrenaline, or the other pharmacotherapies. It can't be work. And it has a rash and it hasn't got rash, so it is the main difference. What is the symptoms of heteroangiodema? Its symptoms: abdominal severe, edema, face, lips, mouth, throat, hand, arm, leg, and the genital. Shortness of breath, upper respiratory tract. If the edema is the upper respiratory tract, so it can be dangerous because it takes a lot of damage to the lungs. All of the symptoms depends on heteroangiodema attacks intensity. So we can see the patients to attack, heteroangiodema attack, then the before picture and the after pictures. This is the face edema, and this is the hand edema, the second picture, and the third picture is the mouth edema. So modern treatment protocols. With the advances in genetics and molecular science, understanding of heteroangiodema is evolved. In the past, antifibrinolytic agents such as the tranexamic acid or the epsilon aminocaproic acid and androgen danazol were the first-line pharmacotherapies for prophylaxis. There were no FDA-approved therapies site-specific for heteroangiodema besides supportive care and airway protection until 2009. On-demand medications have significantly ameliorated patient safety. Prophylactic treatments are effective and safe. With the evolving approach to heteroangiodema, a life-threatening rare disease, patients' daily life improved. So this is the drugs we use in heteroangiodema. The plasma-derived C1 inhibitor was the first new-target prophylactic therapy. Plasma-derived C1 inhibitors, recombinant human C1 inhibitor, especially the bradykinin-based receptor antagonist, icatibant, and the selective kallikrein inhibitors, which is the ecallantide and the lanadelumab, are within the first-line treatments for heteroangiodema with C1 inhibitor deficiency. We can know that the heteroangiodema is a chronic disease and the orphan disease, and it can be treated the modern pharmacotherapies. This is the important part. So it's my references, and I want to thank you listening to me, and I hope we will meet face-to-face Congress at Maltepe University campus. Thank you.
Thank you for your presentation. Is there any questions? Okay, if not, we can continue with our next presentation. Current and Emerging Disease by Ana Maria Minova.
Hello, can you hear me?
Yes, if you're ready, you can start.
Okay, so first of all, my name is Malaria Minova. I am a third-year medical student at the medical faculty of St. Cyril Methodius in Skopje, Macedonia. So first of all, I want to thank the committee for choosing my presentation and for giving me a chance to present it. So today's topic is I will be talking about current and emerging diseases. So current versus emerging. What does current means? Current means something that it is right now in the world, a current disease, and emerging means something that is new and it's wildly globally spread for a short amount of time, just like the COVID. So it is usually caused by an infectious agent, which can be familiar or unfamiliar with. So we can classify the emerging diseases in 4 subtypes. We have re-emerging diseases, that is the methicillin-resistant Staphylococcus aureus. Then, which in Macedonia in 2017 we had 255 cases, and also in 2018 we had registered a new case of a new resistancy, which was a Klebsiella pneumonia. Then we have vaccine-derived emerging diseases, such as the poliovirus, and we have deliberately emerging infectious diseases, such as the bioterrorism, which was anthrax, botulism, and tularemia. Also, we have so the aim of the study it is to see the current diseases and the silently growing situations, because I think that with the COVID situation, we often forgot that there are other diseases than COVID, and a lot of the doctors, in Macedonia strictly, a lot of the hospitals did not let the patients go to their routine checkups because of the COVID, and they were scared. So for this paper, I collected the available data. This is an observational study. So results. An infection can be spread in the span of 24 to 48 hours due to human behavior, rapid transportation networks, and low prices of tickets, this was the case with the COVID, because we saw that in a span of like 2 months, everything got shut down, the whole world, and we were on a lockdown. So here we can see graphics about influenza from the 2016 to 2022, which is interesting because we can see that in the period of 2020, when the COVID started, to the half of the 2021, there were no cases of COVID. There were no cases of influenza. That is mainly because the doctors did not take samples for influenza, and then we can see that from the other half of 2021 to now, we have several cases of influenza. Then we have the Malaria Statistics, in which we have countries that have 0 cases of malaria, and then we also have cases of indigenous malaria. Then we have the non-communicable diseases, which here we can have the deaths of the non-communicable diseases, which we can see the main cause is the cardiovascular diseases, also with diabetes, and also carcinoma. And we can see that the death cases are actually the mortality rate is high. So here we have North Macedonia. So we can see that in the first one we have enterocolitis, which we can see that we have enterocolitis spread seasonally in July and August, over 350 cases. We have Varicella zoster, mononucleosis, and scabies. Something that is characteristic about scabies, it is shown in the places where they are like left out in the smaller cities. And about the non-communicable diseases, we can see that also in Macedonia, the main reason for death is cardiovascular diseases. Also neoplasm, we have the COVID, we also have acute respiratory syndrome, we have the metabolic, endocrine and nutritional diseases, and we also have CNS related diseases. And also in Brazil and Indonesia, we have the dengue, which we have a lot of cases there, but it is not talked about a lot. So the connection between climate change and emerging diseases is that because the world is slowly getting warmer and warmer each day, and with that we have migrating animals that can cause lots of new diseases like zoonosis, and also we have deforestation and we have extinctions of animal. So it is known by 2070 that we will have a lot of new viruses that can cause even bigger pandemics than the COVID one. And then we also have the war and the diseases, which we know that wars have a catastrophic impact, and in which we have a changes on the ecosphere. We have lots of use of antibiotics for not a legitimate reason. And we also have the biological weapons, which they are, as stated before, they are the anthrax, the botulism, the tularemia. And in conclusion, the specter of new and emerging diseases is getting larger and larger each day. We can see that by the amount of deaths we have in the world. Part of it we can call bioterrorism, because we have new methods and new sicknesses that takes upon a large part of the population, and part of it are just simple plain re-emerging diseases that have existed before. Every year there are at least 2 or more new species of human virus, which results in more infected inhabitants and newly deaths, in which we can tell that we don't need to focus just on one disease, because the world is slowly getting destroyed each day, and we cannot focus only on one thing. If we want to change something, and if we want to be healthy, then we have to look out for the nature. And thank you for your attention.
Thank you for your presentation. If you have any questions, we can continue with our next presentation. Knowledge of reproductive and sexual rights among students of KSMA, Illyri Partip.
Hello, yes ma'am. Good afternoon to everyone.
You can start.
Okay. Everyone, and myself is Illyri Partip, and I am studying 4th year MBBS in the Kyrgyz State Medical Academy in the Bishkek. And now today I am going to present about the knowledge of the reproductive and sexual rights among students of the KSMA. What is the importance of the knowledge about the sexual and reproductive rights? And it not only includes the maternal child and the child health and also family planning. It is also a continuum of the care for women and children even after the delivery and before the delivery and from the childhood onwards. So based on these concerning on these, and there was in conference held was at Cairo in the 1994 International Conference on Population and Development. They were recognized that sexual and reproductive health was a fundamental human right, and that empowering the women and girls was critical to ensuring well-being of individual families and nations. And after that, based on the knowledge, so what we had benefit we got. So because of the developing the sexual health and reproductive health with the rights implementing, so there was unintended pregnancies was decreased by 70%, and unsafe abortions was reduced by 74%, and earning potential was increased and maternal deaths was decreased. And so what exactly mean by the sexual and reproductive rights? So sexual and reproductive rights, it's sexual rights, it is right for sexuality and gender, which means that there will be the no inequality in the gender, or which is either physically or emotionally. And then coerced sterilization, and there is a right of female to have the own choice about the in some countries there was a like traditional practices like female genital mutilations and some other con- uh, other traditions. So this was read it was completely right about the female or male, and the relationships maintaining by the sexual relationships maintaining by the men and female, this is their right. And also the mutual respect giving to the females. And what about the reproductive rights? When we come to the reproductive rights, about the spacing and number of children by the concern of the female itself herself, and not by the family or domestic or by a husband or anyone. And the knowledge of contraception and its use, this is very important, because to reduce the STDs which are occurring now and which are occurring, as well as the to safe to control her for unintended pregnancies and safe abortions. And to achieve high standards of sexual and reproductive health, they need the good education facilities which are provided by the government or schools. They have the right same right up along with the males. And next, so we along with my teacher Gulnur, we had conducted a survey about the to assess the knowledge of reproductive and social rights as well as reproductive health among the students from the first year and the sixth year students. And this is why we had made means to achieve this purpose. So we conducted 10 different questionnaire was developed, which was including data such as age and regarding sexual relationships and knowledge, and also about the descriptive questions also we included about how the contraceptive methods were using and how these STDs are occurring. So based on this, we had for this method we had preferred 146 students from total number, and out of them one or two from the first year and 46 from the sixth year. So, and among these, males are more and females are less. Why we chosen males? Because males are for the men are primary decision makers either politically or socially and economic and domestic friends. So we had chosen these males more, and among that we had given only 20 minutes for them without any electronic devices. So they can answer the questionnaire with their own knowledge. And the first year students was freshers, so they don't have any knowledge about the concepts. And now we can choose the knowledge about the methods of prevention and unwanted pregnancies. So the students who have knowledge about the methods of prevention, and those are 81 approx from the first year and 98 from the sixth year, which means that 85% of the students who had just completed her 12th standard, their 12th standard also they got the knowledge of 81. It's happy to hear, because even due to the secondary education they got the knowledge. So education system has developed, and they've had mentioned about the sexual and reproductive rights in their schools also. And when we got the questions and when we got the answer for the questions regarding the HIV transmission, so first year students have got the knowledge about the how the transmission can reduced by the HIV by using the condoms, and this was the main reason they were mentioned. And remaining all the reasons transmission of the STDs or sixth year students got very high prevalent in that. And the symptoms of sexually transmitted diseases and the answers presented by the sixth year students was very clearly, and about they mentioned about the bacterial infections which are gonorrhea, chlamydia and syphilis, trypanoma, which are more cancerous too. So based on this they have the complete knowledge, and the symptoms which are like headaches and cervical discharge or vaginal discharge, and there will be the nausea and vomiting, and these all symptoms has carried by the diseases are known to the sixth year students very well than the first year students. So first year students, they know the physical appearance, And then we can go to the next slide. And here we had made the analysis that who is with when the sexual rights has been beginning, and the answers are there from the first year students. Are answers are they had said that from 18 years or the sexual rights has been implementing, and adulthood has more rights on them, and very least people has answered that from birth. But according to the WHO, there was the sexual rights and reproductive rights has been implemented from the childbirth onwards. And what are the difficulties facing by the students or youth is the fear of leakage of the confidential information is more from the sixth year as well as the first year students, and they are feeling embarrassed to approach the doctor also more, and very few people are hesitating to go to the medical help. And so the conclusion is that the level of awareness largely depends on the age of the young person. And in the adjoining the thematic classes were an additional source of knowledge for students of medical university. And also they know the proper usage of the contraceptives, but people need the knowledge of counseling of the counseling how to use those contraceptives. This is also a very important. So therefore, undergraduate students have shown a higher level of reproductive awareness. Thank you for your attention.
Thank you for your presentation. Is there any questions? If not, we can continue with our next presentation. Climate change impacts on food-borne disease. Johnson. Johnson, can you hear me?
Yes.
Okay. Okay. Slide. Okay. If you're ready, you can start.
Okay. Hello to everyone. I'm Jansun Bukovec and I'm from Republic of North Macedonia, and I come from Institute of Public Health of the Republic of North Macedonia, Skopje. Our topic is climate change and food impact on foodborne diseases. Next slide, please. Climate change are our reality and unfortunately our future. Adverse health effects caused by climate change include heat-related disorders, vector-borne diseases, foodborne and waterborne diseases, and many others. Climate changes will make a lot of changes on the food systems who are very fragile and sensitive. As a matter of course, it will give us many foodborne diseases, and the final outcome of the climate change, as you know, is health consequences of people. Next slide. Methodology. We reviewed the literature on PubMed and Google Scholar database by keywords climate change and foodborne diseases. We included 18 from reviewed 46 articles as is appropriate for the purpose of our research. Next slide. Safer food, better health. There is a mistake. Safer food, better health. Foodborne diseases impede socio-economic development by straining healthcare systems and harming national economies, tourism, and trade. But the good collaboration between governments, producers, and consumers help ensure food safety. Please, next slide. You can see the impact impact of the climate change on human health on the circle. On the bottom of this cycle, you can see water and food impacts, and also water quality impacts. But as you know, water is kind of food, and malnutrition, diarrheal diseases, cholera, and harmful microorganisms are effects of climate change on food. Extreme weather events harm food safety because a lack of rainfall associated with higher temperatures lead to reduced yields, and in the combination with the growing population suffering for food and water is expected. The risk for use of unsafe water uh, and food production, consequently, foodborne diseases will increase. Higher temperatures could increase incidence of foodborne diseases. Yes, please, next slide. 23 million people fall ill, and unfortunately, 5,000 people die every year in the one of the most developed region in the world, European region. Uh, $110 billion is lost each year in productivity and medical expenses resulting from unsafe food in low and middle income countries. But the diarrheal diseases are the most common illnesses and resulting from the consumption of the contaminated food, causing 550 million people to fall ill and 230,000 deaths every year. Major foodborne causes are bacteria, viruses, parasites, prions, and chemicals. Many studies have confirmed the link between non-typhoidal Salmonella, Campylobacter, and Shigella outbreaks and climate change. The relation between Musca domestica and pathogen transmission may range from various food poisoning bacteria such as Shigella and Salmonella. Norovirus and Toxoplasma gondii are important foodborne pathogens and are related with extreme weather events. Humans are important foodborne pathogens who are related with the extreme events, and humans can change the epidemiological patterns of protozoa and helminths, and consequently increase increase the zoonotic diseases such as plague, hantavirus, pulmonary syndrome, Lyme diseases, and etc. But we are expecting increased food contamination with mycotoxins because of the floods and droughts, increased use of pesticides, environmental contamination with heavy metals. Please, next. Foodborne diseases are increasing. Researchers have identified more than 250 foodborne diseases, and harmful toxins and chemicals also can contaminate foods and cause foodborne diseases, because climate change could also uh, increase uh, drive increased antimicrobial use in food producing animals, which might increase occurrence of antimicrobial foodborne diseases in humans. Please, next slide. New realities bring new challenges. Foodborne diseases are closely linked to poverty and low and middle income countries, but are a growing public health issue around the world. Increasing international trade and longer, more complex food chains increase the risk of contamination and the transport of infected food products across national borders. Growing cities, climate change, migration, and growing international travel compound the issues and expose people new hazards. Please next. If we should to conclude, climate change has the ability to disrupt food security by making it more difficult to get food from one region that is able to produce a food to another region that wants to consume it due to vulnerabilities in transportation infrastructure and related trade arrangements. So we can conclude that climate change will increase the rate of morbidity and mortality related with waterborne and foodborne diseases. But the One Health approach is the most appropriate way for the reduction of health consequences caused with the climate change. Thank you for your attention.
Thank you for your presentation. Our next presentation will be uterine artery embolization for uterine fibroid by Monat. Monat, if you're ready, you can start.
Okay, thank you. Hello, everyone. My name is Manat, and I'm a student of Ahumbayev Kyrgyz State Medical Academy. And my theme for today is uterine artery embolization for uterine fibroid. Next slide, please. Oh, I'm sorry. As we can see, there is a growing tendency in the modern world for women to give birth for the first time in their 30s, in their late 30s, and not in their 20s like they used to before. But by this time, by their turn 30, number of gynecological pathologies increases, including uterine fibroids. Since uterine fibroids is so common, one of the most relevant tasks in gynecology is the development of treatment for this disease that preserves the reproductive system of women. What's uterine fibroid? It is a non-cancerous growth of uterus that often appear during, as I mentioned, a reproductive age. What's uterine artery embolization? It's non-surgical, it's endovascular procedure, and the point of it is the obturation of the artery that supplies the fibroid, as you can see on the picture. And in comparison to radical surgeries that were used before, there is less traumatization, less blood loss, and patients are conscious during procedure because they're on light sedation. Also, it helps us to preserve reproductive system. It has minimal side effects and it has short-term recovery time. For better understanding and for better memorization, we can compare the process to grape that dries to raisin. At the beginning, it is like pulpy, fruity, fresh, but by the time it dehydrates and becomes smaller. Why we've done this research? What was our aims? We wanted to review the efficiency and the safety of uterine artery embolization as a treating method for uterine fibroids. What materials and methods we used? First of all, we've done prospective analysis of 34 uterine artery embolization cases were done here in Kyrgyzstan. And then there were patients, and patients' average age was circa 33 years, and the duration of the disease varies between 2 and 11 years, which is 5 on average. Also, in this case, we in this 34 cases, there were all types of uterine fibroids, including intramural, submucosal, and subserosal. Most of these were intramural, as you can see on the picture. What were indications for the procedure? They were the same as for surgical treatment. First of all, menstrual disorders that caused anemia. Second of all, fibroid cluster size that was larger than 13-14-week pregnancy. Third of all, tumors' rapid growth. And last but not least, functional faults of neighboring organs. Discussing results. You can see here 2 pictures. The one was the first one, angiography, was taken before procedure, and you can see a huge blood flow of the tumor using contrasting agent. And on the second picture, you can see that there's no blood flow. That means that there's no nutrition supplements, and it means that there will be no more growth of the tumor. Was the case of the right after the procedure. But what happened by the time? Within 6 months after procedure was performed, fibroid clusters size decreased up to 29.9%. Uterine size reduced compared to preoperative size up to 31.9%. The compression of nearby organs and pain syndrome decreased due to the reduction of uterine, and it was 60%. Furthermore, the duration of menstruation and volume of menstruational fluid was significantly decreased and contained 33.3%. We were talking at the beginning about the reproductive system a lot. We need to keep it because women want to give birth. So what happened? What about reproductive function specifically? We had 34 cases. 14 of them got pregnant within 6 months. Unfortunately, 4 of them had spontaneous abortions. So doing some mathematics, 10 of them delivered. 6 of them was successful. 4 of them was also successful, but were preterm. Why I say that they were also successful? Because all of the children, by the end of the day, were alive. And we think that it is a success. Talking about numbers again, we were talking about 34 cases, 10 of them gave birth. It is 29% in 6 months. We think that in such a short time period, it is a good numbers. In conclusion, I want to say that uterine artery embolization is a minimally invasive and innovative endovascular procedure. And in many cases, it excludes the necessity of performing radical surgeries that traumatize women while preserving the reproductive and also menstrual function of women with uterine fibroid. That's it. Thank you for your attention. If you have any questions, you're welcome.
Look like we don't have any questions, but thank you for your presentation.
This is the place to find yourself.
Istanbul offers great universities and the lifestyle is really amazing here.
So I live at the dorms at Maltepe University, and I'm really happy with it. There's a cleaning service every few days, and then there's the library nearby, which is open 24/7.
My first impression when I came was like, it's huge. You have everything in one place.
When you first come to Maltepe University, you don't know where what is, and you're like, oh my God, I need help. Guess what? You're not alone. There is the international office people over there. They're like family. They're very helpful, and they're always there for you.
Istanbul is the perfect mixture between ancient and modern. Coming into this city helps me discover myself, learn about so many different cultures, learning about the world, which will help me in writing future books.
At Maltepe University, we have a lot of research centers. Because of that, we have the ability to participate in a lot of international projects.
Here at Maltepe University, the education consists of both practical and theoretical. We get the opportunity to practice everything we learn in class in real life. So after we graduate, we have a degree and we can work all over the world.
People come to Istanbul all the time, but what they really miss when they visit are the antique shops, which contain thousands of years of memories and also a thread of the modern future.
I like to use every minute and just get out and hop on the ferry and just go from the Asian side to the European side and just enjoy the wonderful weather with the wonderful Bosphorus behind me and just enjoying the moment of Istanbul.
Istanbul is very beautiful with great culture.
This city is the symbol of diversity. Come and study at Maltepe University.
Come here and feel like you're home.
Our next presentation will be modern management of the first stage of physiological labor in the Kyrgyz Republic by Nandini.
Presentation.
Hi.
No, you don't know just now. Oops. Yes.
Hi,
Yes.
can you hear me?
मेरा नाम hello.
Hi. Can you share your screen with me?
Yeah, sure.
Or your slide? Okay, you can start when you're ready.
Yes. Hello everyone. Good afternoon. Myself, Nandini. I'm fourth year medical student and studying in Kyrgyz State Medical Academy. First of all, I would like to present my scientific work on my topic, modern management of first stage of physiological labor in the Kyrgyz Republic. That's my topic. And this is on a cervical dilatation as an 3 centimeter, 6 centimeter has been a comparatively threshold for the active phase of most of the women. The beyond the 6 centimeter of dilatation is achieved, the standard of active phase should not be appropriate. And the latent phase of the first stage is pretend to be the characterized by the painful uterine contraction and variable changes of the cervical area. And the mean of the degree of the effacement of now various show the program of distension up to 5 centimeter from first and the subsequent labor. And the active first stage is a period of time characterized by the regular painful and uterine contraction, a subsequent degree of cervical effacement and more rapid cervical dilatation from 5 centimeter until full dilatation from first and subsequent labor. Today and yesterday, it was a dispute in between the WHO and American College was and remained controversial. But earliest was the WHO was believers the active phase of the first stage of labor. It was beginning into 3 centimeter to 4 centimeter. But today he is believing 5 centimeter. But American colleges was believing in the 6 centimeter is better for efficacy and safety of pregnancy. And the main aim is the study of effectiveness and safety of managing physiological labor under the condition of the beginning of the active phase of the cervical dilatation from 6 centimeter. This our main design, as there are many historical controversies of deliveries we perform, but we are dividing the main two categories of group A and group B. In group A, which are standard medical physiological labor, which are under intervention of the active phase of 6 centimeter, and group B, the standard physiological labor of active phase of 3 centimeter, which are without limiting latent phase and active phase. In active phase from group A, which are very easily to assess an effacement of delivery without any abnormality, any anomalies have there. But in group B section, there is some hypocontractility and uterine dysfunction mortality we are assume, and increase the rate of a cesarean section at least 1.5 rises of cases we are seeing. And these are some inclusion criteria. These are seen, such as an cephalic presentation and term pregnancy, 37 to 41 gestation weeks, and singleton pregnancy, spontaneous onset of labor, and some risk factor and intact labors we are also seeing. The main assessment of criteria, it was we assume the effectiveness and safety, how much the total duration of labor, and any abnormality, any pathology we are assume, and any perinatal outcomes, how many volume of blood loss, and rate of cesarean section and septic complication we also assume in this criteria. This was a result, which are further divided into two categories, group A and group B. Group A, which is the main group, and group B, which is the control group. We assume the total duration which we should be higher in the main group, near about 18 hours, and as compared to group B. And this is for very good for main group, because it was very higher in the Apgar scale score, greater than 7 in the first minute, and rate of cesarean section should be lower on that area, on that graph. And this is a pathology of contractile activity shown in the mention in your chart on your display section, group A and group B. And this is an Apgar score, which are characterized by group A and group B. Group A, which are on active phase of 6 centimeter, their delivery of the first child in the first minute, the ratio of 89.4% should be higher as compared to group B. And this is on rate of cesarean section control of data as compared to active phase of dilatation 3 centimeter and 6 centimeter, as in comparison in between the chart. And we assume the mean data, the septic complication we found, group B is higher as compared to group A. And the main conclusion, the total duration of a labor, hypercontractile uterine dysfunction, rate of a cesarean section, and perinatal outcomes, the lengthening and the total duration of a group A should be higher, and we assume the physiological labor for active or dilatation of a 6 centimeter of first stage of labor is very good. Thank you for your attention. Have a good day.
Thanks all the participants for their speeches. Now I close my session. We will see in 1 hour. Next session will start at 3 p.m.
Zorlukları geçtin, yeni evine hoş geldin. Hayatın 4 mevsim, sonbahar bu kez. Başlangıcı hayallerinin. Kış günü yarının yükü omzunda. Ama çalışmaya, kelebek gibi kanatlanıp uçmaya, arılar gibi çalışmak gerek bazen, sonunda kavuşmak için yazar.